Hey everyone, this is Dr. Ishfaq and you are watching the Medical Forum. Today let's discuss how to ace your cardiovascular system short case. Whether you are an MBBS student in your local faculties or if you are doing your final MBBS or MD in a foreign university and you are doing ERPM. So you all are welcome to watch. So how to ace your cardiovascular system short case? So basically, tackling short cases is a skill, right? It involves you to know the concepts, and also it involves you to have practice, okay? And then it involves you to have a knowledge about good technique. So the concept, the practice, and the technique. So that is how you ace your cardiovascular system short case. So basically, we divide the examination sequence into a general examination and a cardiovascular proper. Cardiovascular proper examination, right? Let me first talk about the general examination, right? So the first thing what we need to know is that what's the examination routine. So number one, in under general examination, number one, you need to introduce yourself, right? Introduction. So basically, introduce yourself and explain the procedure to patient. So here you are ensuring that proper positioning of the patient and adequate exposure. So under introduction, you take consent, then explain it to the patient, then exposure and positioning. Exposure and positioning. Then what you do is you need to perform a quick visual inspection. You need to perform a quick visual inspection so that you look the surroundings of the patient, and if there are any clues which the examiners have kept at the bedside, right? For example, it's relevant in a respiratory system where the patient's table would have a space device. They would have inhalers. They would have those dry powder inhalers, right? So having those in the table, it shows that the patient is asthmatic, using inhalers. So those are the important clues you take. Now then, we'll start off with the general examination. So to start off with it's better to have a systematic approach, right? So first of all, now during the quick visual inspection, uh, what do is you tell the patient that you are going to look at him from far. You are going to look at him from far, look at his precordium. Are there any deformities like pectus excavatum deformity, or any pigeon chest deformity, or any surgical scars like a midline thoracotomy or a lateral thoracotomy, right? A midline sternotomy scar or a lateral thoracotomy scar. So all these has to be seen in the quick visual inspection. So any deformities, any scars, right? And then presence of cannula. If there is a cannula, you know that the patient is having some IV drugs, right? So if the patient is catheterized or not, if he's catheterized, most likely the patient is very ill to go to the washroom, right? These are the clues you get from your visual inspection. Then what do? You get closer to the patient. You get closer to the patient, get closer to the patient. And then what do? Here, you first check, is the patient febrile or not? Then, is the patient pale or not? Then, whether there is any icterus, yeah, whether there is yellowish discoloration of the sclera. Then, quickly check the oral hygiene. You tell the patient to open the mouth and see if there are carried teeth and if the oral hygiene is quite bad, because if the oral hygiene is quite bad, this could be even a case of infective endocarditis. So this could be the source. Then what do? You just inspect the JVP, inspect the neck veins. If you feel like they are congested and elevated, you need to ask the examiner that you would like to examine the jugular venous pulse in a proper technique. So you need to make sure the patient is inclined at a 45-degree angle to see the jugular venous pulse. Right. Then what do? You quickly move to the hands. So what do you see in the hands? So you can see clubbing. You can appreciate any peripheral stigmata of infective endocarditis. So what do you have for infective endocarditis? You have Janeway lesions, you have Osler's nodes. So you need to palpate for them. You need to show the examiners that you are checking for them. Janeway lesions, Osler's nodes, right? So after clubbing stigma and checking for peripheral stigmata of infective endocarditis, then what you do is, then you go to the legs. After you go to the legs, then what you do is you check for edema. You check for edema, and under edema, you have to see if they are pitting or not. You need to show the examiner, are they pitting or not. The correct way to examine a pitting edema is you need to compress the skin against a bony prominence. You need to compress the skin against a bony prominence and make sure you look at the patient's face that time, because for some patients it does hurt. So if it is hurting and if you do hurt the patient, definitely either you might fail or they'll penalize you. So make sure you look at the face of the patient when you are checking for pitting edema so that you don't hurt the patient. Right. Then that's pretty much it for the closer examination. And then one thing which I did forget is check for cyanosis, because the patient can have congenital heart diseases, right? So you need to check. Next, what else do we have? Next is, then you have to go to the pulse. Now, under the pulse, basically it has two components. One is the arterial pulse, and after that you need to make sure that you have to examine the jugular venous pulse, right? So when you are checking the arterial pulse, you need to count the rate of the pulse appreciate the rhythm and character of the pulse. And to appreciate the character of the pulse, you need to check the character of the pulse in the carotids. Then you have to check for a collapsing pulse, and then you have to check for radio-radial or radio-femoral delay. Radio-radial or radio-femoral delay. Then most important thing is you need to see if the pulse is collapsing. For that, you need to make sure if the pulse is bounding. If you feel the pulse is bounding, then check if it is collapsible or not. So how do you check for collapsing pulse? So first of all, you need to make sure that the patient does not have any pain in the shoulder. Then locate the radial pulse. Then place your palm over the radial pulse, and relax your grip until you do not feel the pulse. Then what you do is you slowly raise the arm of the patient's you slowly raise the arm above the patient's head. So if it is a collapsing pulse, you will find it knocking your palm. So that is a collapsible pulse. It's usually prominent in bounding pulse. Next is you have to check the JVP. So you need to ask the examiner that you need to have proper positioning of the patient. So most likely they will not tell you to do that. At the end of the pulse examination, because since you are still in your hands, ask for blood pressure. Always ask for blood pressure. So in this, you might get a clue about the pulse pressure. So if the pulse pressure is either narrow or wide, it will give you clues like in AR and in AS, right? So that is for the blood pressure. After that, then you move on to the precordial examination. So next, what we are going to talk about is the cardiovascular system examination proper. So it has certain components. So you have inspected already in the general inspection, you've taken an idea, but you still have to show the examiners that you are inspecting, and I'll tell you what are you trying to inspect. Then you go for palpation. And then you don't go for percussion. You don't do percussion in the cardiovascular system. It's not relevant. And then the most important thing is the auscultation. So inspection, palpation, and auscultation, right? Okay. So what are we trying to inspect? We are trying to inspect any chest wall deformities, like I mentioned. Deformities. Next, any visible pulsations, like any visible apex beat or any visible other pulsations in other predominant auscultating areas. Then you check for surgical scars. The surgical scars might tell you that the patient would have had a CABG, the patient would have had mitral valve replacement, right? So those things should be seen. The next, you have to go to palpation. Under palpation, the number one is, after you've inspected, is there a visible apex beat? Let's say you don't see an apex beat. So then first you start palpating. You need to look, where is the apex beat? So Feel for the apex beat, locate the apex beat and describe the character. It could be tapping, it could be heaving, it could be thrusting, right? So you need to look for the character and describe it. And then you need to be able to locate it. Is it in the normal place or is it deviated? Then you have to feel for other palpable thrills. Number one is a parasternal heave. You have to see for a parasternal heave. Then you have to see any other thrills in major points. What do I mean by major points is in the aortic area, pulmonary area, right? The aortic area and pulmonary area. You need to see, are there any thrills or palpable sounds? Then finally, you go to auscultation. So under auscultation, you need to make sure you remember this order. The number one point to keep is your apex. So that is the mitral region. Then you need to keep it in the left lower sternal edge. Left lower sternal edge. Now that is the tricuspid region. Next, you go to the pulmonary region. Pulmonary region, which is the second intercostal space. Second intercostal space, left side. The second intercostal space, left side, which is the pulmonary region. So I do remember it that the pulmonary has an L, so that is left. Next, finally, the aortic region, and it is in the second intercostal space, right side, and aorta has an R, so that is why you go for the right. And finally, to finish it off, you do the relevant locations. So first you go to the apex, mitral region. What are you trying to assess here? You are hearing the S1 and the S2. Here, predominantly in the apical region, you are checking the S1. What is it, loud? Is it soft? Right? Then you go to the tricuspid region. So tricuspid region also you appreciate the S1. Pulmonary region and aortic region, that is where you appreciate S2. So usually there are two components. So S2 is divided into an aortic component and a pulmonary component, and usually during inspiration there is a physiological splitting, because during inspiration the pulmonary component remains open for a longer period of time. Because of that, it closes late. So you might hear a split. Sometimes you might not hear, but you need to train your ears to hear the split. But due to some conditions, systemic hypertension, you can have the aortic region to be more louder. So that is called a A2 accentuation, an A2 accent, or you can say a loud A2 or a P2 accent in pulmonary hypertension. Pulmonary hypertension, pulmonary embolism, right? So you see a P2 accent. So you need to make sure you look for these things. Then what do I mean by relevant locations is that when you auscultate, you are mostly focusing about murmurs. Am I right? So murmurs. So when you hear a murmur, number one, it is the area where the murmur is best heard. Is it in the mitral area, tricuspid area, aortic area, pulmonary area? Where is it best heard? Then what is the timing? What is the timing of the murmur? Is it a systolic murmur? Is it a diastolic murmur? So if it is a systolic murmur, is it a pan-systolic murmur, or is it uh, early systolic? Is it a late systolic? If it is a diastolic murmur, is it a mid-diastolic murmur, right? Or is it an early diastolic murmur? So that timing is important. And how do you know this timing is you ask permission from your patient, keep the fingers over the carotids, because that is where you feel the pulse character the best, and then auscultate and find out S1 and S2. So you would know that whenever you feel the upstroke of the pulse, the sound closer to the upstroke is the S1. So usually the gap between S1 and S2 is a smaller gap in compared to the gap between S2 and S1. So this is your diastole and this is your systole. So if you hear a murmur in this region between the two sounds, it is a systolic murmur. If you hear a murmur during this region, it is a diastolic murmur. So timing of the murmur is important. Next is the radiation. The radiation is very important because each murmurs, depending on the etiology, it can radiate to various regions. So, for example, if it is a problem in the mitral valve, it could be either a mitral stenosis or a mitral regurgitation. So, a mitral stenosis would be heard best at the apical region. There might not be a certain radiation. Mitral regurgitation also will be heard in the apical region, but it does radiate to your axilla. It does radiate to your axilla. So likewise, the aortic stenosis radiates to your carotids. So you need to know which type of murmur will be heard during which region, right? And then you need to know that there are some dynamic maneuvers. There are some dynamic maneuvers to examine murmurs. Let's say apical region, you need to turn the patient to the left lateral side and you need to tell the patient to take a deep breath and exhale and hold the breath on exhalation. Hold the breath on exhalation and you have to listen to the murmur at the apex. When you're looking for an aortic regurgitant murmur, you need to make the patient sit up, lean and bend forward. Take a deep breath, exhale and hold the breath on exhalation. So these are the dynamic maneuvers which we will be discussing in another video, which you'll have to master. Then you have to go for a extended examination. Now, what do I mean by an extended examination? Let's say now you have found out that there is a murmur and you've kind of concluded that it could be a MS or it could be a MR or it could be a AR or an AS. Now, the extended exam actually targets to find what is the etiology. Are there any complications? What is the etiology and are there any complications? So basically, the etiology, whether it is something of a rheumatic heart disease in origin, whether it is an infective endocarditis. So for that, you need to see if there, for infective endocarditis, you need to see if there is any splenomegaly, are there any peripheral stigmata of infective endocarditis, and if it is any rheumatic heart disease, to check for other conditions like any skin nodules, any presence of coriform movements, right? And then complications. So what are the complications these patients with murmurs or valvular lesions can have? They can go into heart failure. So you need to examine the basal portions of your lung posteriorly. So you need to offer it. You need to ask from the examiner that, may I examine the basis of this patient's lungs? So I want to see if the patient is in heart failure. Then what do? You need to make sure now the patient might be in an atrial fibrillation due to a valvular lesion. So patient might be on warfarin. So the patient might be on anticoagulation. So are there features of overcoagulation or undercoagulation? So they are treatment complications. So you tell the patient to stretch out his arms and check for a pyramidal drift. You check for a pyramidal drift. So if there is a drift, there has been a thromboembolic complications. That means there is a feature of undercoagulation. And then finally, you have to see if there is hepatomegaly. Tender hepatomegaly can be evident in a congestive hepatopathy due to congestive heart failure, and that will show you the etiology and the complications. So when you are presenting your findings, so start with general examination. Specifically mention cyanosis, peripheral edema, and peripheral stigmata of endocarditis. Mention the arterial pulse and the JVP. Mention you would like to measure the blood pressure. Present the precordial findings afterwards as inspection, what do you see? Palpation, what do you see? Auscultation, what do you see? And then you go for heart sounds in auscultation and explain the heart sounds, the murmurs, and then present the lung findings and comment on hepatomegaly. So you have to mention what is your diagnosis, what is the severity, what are the complications you found, and the possible etiology. And that is how you present a cardiovascular system short case.
Good morning, sir. I examined this gentleman who is dyspneic and he is afebrile and he is not pale and not icteric and he is not cyanosed. He has a satisfactory oral hygiene and he does have a cannula on his right hand. He has no clubbing or nicotine stains and no peripheral stigmata of infective endocarditis like Janeway lesions and Osler's nodes. He does have bilateral pitting ankle edema. His pulse rate is 110 beats per minute, which is irregularly irregular with no radioradial delay or radiofemoral delay. The character of the pulse was of normal character, and I would like to check the blood pressure and also check his jugular venous pulse with proper positioning. On his cardiovascular examination proper, there was no surgical scars and no obvious deformities. There was no pulsations or thrills. His apex beat was at the left midclavicular line at the fifth intercostal space and it was tapping. There were no parasternal heaves or other thrills elsewhere. On auscultation, loud S1 was heard at the apex and loud P2 heard at the pulmonary area. There was a mid-diastolic murmur heard when the patient was turned into the left lateral position. There's bibasal crepitations in his lower zones of his lungs, and there were no hepatosplenomegaly. There were no features to suggest over or undercoagulation. In summary, this patient is having mitral stenosis complicated with atrial fibrillation and heart failure with no apparent treatment complications. The most likely etiology is rheumatic heart disease.